pre-morbidly she had Prader syndrome. From the history, I have gathered a few issues related to the underlying disease and also current examination. So for the first one is currently the current issue is actually severe community-acquired pneumonia with underlying Prader syndrome with other comorbids, which is metabolic syndrome involving of hypertension, morbid obesity with type 2 diabetes mellitus. The other comorbidities is actually sleeping disorder breathing with central hypoventilation and also obstructive sleep apnea. The third one is learning disability with underlying Prader syndrome and pubertal delay, likely hypogonadotropic hypogonadism.
Alright, so basically out of all the issues that you have listed, which one is currently the active one?
Severe community-acquired pneumonia.
Okay, other than the acute infection?
Uncontrolled DM.
So uncontrolled DM. So do you think it's because infection related, or do you think memang she already has uncontrolled DM from previously?
Because according to the mother, sugar monitoring at home usually is actually based on the monitoring at home twice a week, range around 7 to 8 in more, which is I think is acceptable for.
What was the HbA1c before?
Mother cannot
remember. Okay. So do you think from the history wise, patient have uncontrolled DM symptoms or not?
There is no symptom of hypoglycemia, in which I didn't mention. There is no UTI, there is no vaginal discharge, there is no sign symptom of polydipsia or any polyuria, and there is no previous history of patient related to the poor sugar control and any diabetic ketoacidosis, in which currently well controlled with two diabetic medication is empagliflozin and also metformin 1 gram.
Any acanthosis?
Yeah, there is acanthosis.
Grade what?
Green.
Okay, don't know the grade. Fine, then how's the sugar level in the ward?
So the sugar level award is around 15 to 18 mmol. However, there is no evidence of elevated ketone or any acidosis. So she is not in DKA and also requiring additional of sulfate insulatide in ward, which is tapered accordingly and was discharged with sulfate insulatide 18 unit on 9.
Are they compliance to the medication before insulatide?
Yeah, she is well compliant and mother always come every 3 monthly for the follow-up. They have very good social support from both mother.
So what are the issue when patient started on insulatides? What are the main thing you have to address?
The first one is actually self-administration because she is already 19 years old and mentally is actually ADL dependent. But knowing with background of learning disability, so we have to, for the first time, actually we have to mother have to supervise her injecting the insulatide especially, and also need to remind regarding the site of injection.
Can she inject herself? Cannot? Or the mother have to inject?
Mother have to inject.
Okay, alright. So, other than the DM, the hypertension, what was the BP? Okay or not?
BP in ward is actually at 10 to 15 centimeters, which is controlled with single antihypertensive medication, which is Prader 4 mg only, and not requiring for any additional antihypertensive control during this current action. And I think, and also there is no target organ damage involved as well that is screened for.
So I have been screened before?
Urine, as for according to mother, the urine is normal.
RP normal?
RP also normal.
Echo, no LVH, chest x-rays?
Chest x-ray, there is evidence of infection. However, there is no cardiomegaly.
NYHA kelas berapa?
NYHA, so initially NYHA, okay, I got history lah. Actually, I got reduced effort tolerance during for the past 1 week because I'm unwell. Initially NYHA class 2, but because of the unwell, she is unable to walk to toilet short distance and also even at rest. So at least NYHA class 4.
What?
Class
At home? At home too?
At home too.
Okay lah, tu lah. Alright. Okay, then all metabolic screening done. So the DM, I'm not sure. You haven't mentioned. This one since when?
15 years old.
Since 15 years old.
15 years old.
Okay.
Monitoring of food.
Alright. So from the history alone, I don't think patient have any the OSA seems like quite well controlled, well managed. So it doesn't sound like patient have primary hypertension. But I'm quite interested why this patient diagnosed late and then at 5 years old. I know she defaulted follow-up, but why do you think patient have poor weight gain during the infancy?
Why? So from the history from mother is actually the first month of during the antenatal period there is no intrauterine growth restriction, there is no polyhydramnios, and also there is no reduced factor at the moment that is suggestive for possible Prader syndrome. However, during the first 30 days of life, she had poor weight gain that requiring, mother can't recall, but during the first 30 days, she was admitted for almost 1 week because of the poor weight gain and had difficulty in feeding. And since then, she required rice tube feeding.
So that one doesn't question you all the why need rice tube feeding?
Because of
in regard to Prader-Willi, why do you think patient need? In regards to Prader-Willi, why they need the rice tube feeding? What's wrong with the Prader-Willi babies?
What's wrong
During infancy, what are the main issue during the infancies? Leading to poor weight gain, leading to feeding issue.
Hypotonia.
Yes, hypotonia lah. Okay, so why at that time he wasn't picked up, and then only defaulted follow-up and diagnosed at 5 years old. Then that brings to my other question: why this patient never on growth hormone therapies?
Because why she's not under growth? Because actually detected. I did ask both parents, but actually mother. Because actually late detection already, that is only made by 5 years old, and then there is no and on top of that she also had all the
So at that time, at presentation, patient already obese, is it?
Yeah, already obese.
Okay.
So that one, because we worried on the possible of the because
Okay.
child might have the.
Alright. So currently the weight and BMI is at what?
Currently is 91.3 kilogram, which is static for the past 1 month. Height of 143 cm, weight less than third centile, and with BMI of more than 95th percentile.
Alright. So patient already adult. So going forward, what is the main focus on managing this patient now? The specific thing you have to focus. Other than which problem do you think need to be emphasized?
Even actually by the age actually she's 19 years old, but because of the learning disability, during the interview I did not seem to notice any possible of teenage adolescent issues like rebellious or any stress, because of most of the time she's very cheerful kids, and as for now she know actually she needs to compliance to all medication and taking all the medication and taking and mainly she can taking care of herself about the daily activity, social, and also can helping with some business as well.
So I know she is ADL dependent, but can she do the basic thing, taking care of herself?
Can because during the menses she can, especially the menses, she can taking care of herself. Just only need some guidance from the mother, but mainly can help with the house chore as well. She likes to do help with cooking as well, but the main her hobby is actually coloring. It's very interested in colouring.
So the main social issue is just financial.
Yeah.
Any other issue? Who's taking care of her? Primary caretaker?
Mother is the main caretaker.
Mother is how old already?
45 years old.
Mother is still so young. 45.
45 years old.
Okay.
45 years old.
The father?
The father is 46 years old.
Siblings?
The elder sibling is 25 years old. The elder brother, which is own their pet business.
So dia kerja at the pet business for the brothers lah.
Since after she's finished schooling, attended PKPI during the secondary school.
I think you forgot about your social history.
Yeah, forgot.
Yeah. So all the thing about loan case you must find out the social issues. You don't
have. You may like,
No. Basically, you have to tanya. You have to correct. Even though they don't know, there might be a social issue. Okay, the social issue not necessarily just financial. There's a lot of social issue you have to find out lah. It can be the simple sibling rivalry, siblings, like kind of like neglect because of the thing. All these things you have to find out lah. Okay, financial is just all straightforward thing you have to find out lah. But we don't know because with patient, the siblings already 25 years old. They are quite big, so that's one is not an issue anymore lah. Other than the social issue, other than financial, how are they coping also? How are they coping with the disease? Patient, parent, coping also part of your social punya issue, right? The coping in terms of how do they coping at home, how do they coping with the transport, going to the hospital and all that. If patient recurrently admitted, how are they coping mentally as well? And then we don't know this patient with chronic diseases for sure have some mental health issues. So at least parents wise or siblings lah, that one you really have to find out lah. Mentally kena tanya lah any like breakdown into parent. You will see this patient in chronically stay and all that, the mother will for sure have some breakdown or something lah. Okay, that's all those things you have to study lah. The social issue too, you have to find out. Even though there is no specific problem yet you can identify, but you have to ask all these things so that you can find out the problem lah. You got 1 hour to clock kan, so easily can find out one. Okay, this patient come with acute exacerbation like this. Have we like discussed to the any advance directive or not?
Tak ada.
Ada.
No, not to the extent advance.
I know that the prognosis still not too bad lah, but how to intubate ah? Very difficult lah kalau datang severe exacerbation like this. So I think that question, so you have to also bring into the social issues also lah, especially the chronic one like CPs, any advanced care punya plan. Even though kalau tak pernah discuss, you all have to discuss lah. Okay, kalau patient CPs never been discussed, part of your management, advanced care you have to discuss juga. Kalau advanced, especially CP yang memang backbound and all that tu, for sure dia dah probably have mention. Kalau tak mention, lagi senang lah you all nak manage. Tapi kalau dah mention pun need to re-emphasize, sit down balik. So kalau this patient kita kena intubate ni, nak panggil siapa ni? I don't think NS lah, but PICU people have to be there lah. But at night, for sure you panggil NS lah. I wouldn't intubate lah on your own sekali. So know the limitation lah sekali. Since patient tak ada advanced care punya plan, so datang with acute infection like this, acute issue like this, you have to treat lah. So pada Willi growth hormone, the complication apa? Contraindication to start growth hormone? Because what happen if you start patient on growth hormone therapy, they have OSA? More hypertrophy lah, so cause airway obstruction lah. Other than that, apa lagi contraindication? Yeah, if got some hypokyphoscoliosis also can worsen also lah. If patient have uncontrolled DM already, cannot start lah. Okay, so but if got treated Severe OSA still can consider lah. Okay. So when patient started on growth hormone, what do you need to monitor patient Prader-Willi? Sugar, sama? Echo, monitor apa? You need at least yearly echo screening lah. Because growth hormone so it can increase growth in the heart. So can cause what? LVOT obstruction, hukum lah. One of the possible complication. Okay. Okay. Alright. So if patient treated Prader-Willi with growth hormone, what are the phenotypes? Usually, are they obese or not? Have you all seen Prader-Willi on growth hormone? What are the phenotypes? The typical Prader-Willi phenotypes apa? Obese, short and obese. Okay, but patient on Prader-Willi on growth hormone, the phenotypes, they're very lean, very small. Okay, so that are the benefit of growth hormone lah. You can see a very remarkable difference compare those two phenotypes. Okay, but yeah, is patient Prader-Willi on growth hormone come for exam? You for sure don't know this my patient. Ada Prader-Willi on, except they are very fair, and then some element are shade. That's all. That's all the finding. But when you ask the parent knows lah. Okay. Probably this patient missed the growth hormone part because she's 19 years old. Diagnosed at 5 years old. That time was how old? 2005. Diagnosed maybe 2010. I don't know lah whether they have started growth hormone therapy in UM or not at the time. So probably the issue with the resources lah, they haven't started the thing. UM is the first one started growth hormone therapy in Prader-Willi lah, our endocrine. But I don't know first patient at how since 2001. Yeah. So I don't know exactly when they started giving it regularly lah. Alright. But the main thing is not just for the obesity, because when you started the growth hormone, they're not obese yet usually. Okay, but the main thing they started the growth hormone is to increase the muscle mass. Okay, so why patient Prader-Willi have hyperphagia? So what chromosome involved?
15q.
So what kind of mechanism problem? I have to ask all this lah. Prader-Willi is a 10 must know syndromes. Okay, out of 10 must know syndrome. Down syndrome tolak tepi already. So okay, the 10 must know syndrome, one of it is Prader-Willi, your Williams, George, and all that. You have to know a bit more details. Okay, so chromosome 15. So apa mechanism of epigenetics in Prader-Willi? So parental
deletion.
Okay. So which one? Father or mother deleted?
Father.
Okay. So in imprinting you get this gene from both parents, right? Okay. So father one, mother's one. So kalau in Prader-Willi your normal copy should be from the father's one lah. But somehow the imprinting happened, mother's one got silence, then father's one also abnormal. So you get no copy at all lah. Okay. Kalau enchantment terbalik. Okay, the abnormal copy is the silence one is the father, but the abnormal copy come from the mother lah. Okay. Alright. So it is stopped somehow because of the disruption in chromosome 15, so it affects the function of your hypothalamus lah. So one of the function of hypothalamus include your appetite and all that lah. Okay, so appetite kacau your satiation center lah, satiety center, so that's why they have hyperphagia. On top of it, your hypothalamus also produce oxytocin, so involved in the satiety as well. So lack of oxytocin also believed to have causing all this thing lah. And then Prader-Willi also have what level tinggi? Ghrelin level hormone also involved in the hyperphagia lah. Obese patient high ghrelin, more appetite nak makan. So low leptin lah. Kalau dia ada one terbalik high leptin, low ghrelin, dia rasa senang kenyang lah. Okay. So most of Prader-Willi's problems in childhood apa? Behavior. Diorang kan compulsive. Pernah tengok tak? Very compulsive. Senang jerit, senang tu. They quite friendly jugalah, but they are quite compulsive. High tolerance in pain lah, ada skin prick apa semua tu kan. Okay. But I think the main issue is the behavior is a compulsive behavior lah. Okay. Prone to anger lah also. Alright. So if patient have already primary hypertension, what you all want to do? You treat the sildenafil, yes lah, but the main issue is apa? What's the primary cause of pulmonary hypertension?
What is the cause? SAR is actually well controlled.
Not really well controlled lah, 30 over 10. Okay lah, since like
Maybe have to change to all days biped. I don't know.
Yeah lah.
Instead of overnight biped.
But it's not improve the
Must see the
activity
CO2
also.
So it's a very advanced case actually.
so the pulmonary hypertension treatment is always treat the underlying cause first. You don't treat underlying cause probably. This one is an airway problem lah. Okay, then it could be lung problem. Kalau you don't treat the underlying problem, you bagi sildenafil ke whatever, but it doesn't work. Okay. Of course lah, this one they probably have tried so many, it's still worsening. Of course at one point kena start sildenafil lah. But sildenafil start pun won't fix the problem lah kalau underlying problem you haven't fixed, but it can lah help also lah. Right? Because sildenafil is just one of the option of treatment. But there are two groups usually we can start for under pulmonary hypertension. There are three groups of drug for pulmonary hypertension. Your sildenafil is your PDE5 inhibitor, which is your sildenafil, tadalafil, all those group lah. Okay. And then there is also endothelin receptor antagonist. So kalau you hear the nama tan kat belakang tu, bosentan, macitentan, those are anti-pulmonary hypertension jugalah. Okay. Then also last kali your prostacyclin lah, which is one IV is the ibuprostenol, just to trigger up. So this kind of patient, most of the time you don't go into the second line, third line lah. Usually we reserve this for idiopathic pulmonary hypertension, okay, or primary pulmonary hypertension. Because pulmonary hypertension pun ada four categories. Idiopathic is one, primary is one, then your congenital related heart another one, then the last one is lung related. Okay, so lung related, we wouldn't even bother to start the second, third line ni sebab you know the lung is a problem. Dibagi most of the time sildenafil is enough lah. Okay, because the treatment for the lung is always your COPD, immunosuppression, CPAP. You don't treat the lung properly, selalu dapat recurrent infection, your pulmonary hypertension pun get worsen lah over time. Okay.